I'm Dr. Amir Zaheer. I'm currently working in Mukhtar-e-Sheikh Hospital as a consultant general surgeon. Today I picked this topic because काफ़ी common complaint है ये जो हमारे OPD में present करती है, and I thought कि I should discuss few points regarding this with my colleagues. So I'm going to present constipation from a surgeon's point of view, that how we see these patients and how we treat these patients in our clinic setup, and then if they require surgery, how we proceed with that. So in this basically I will first tell what is constipation, medically what is the definition of constipation, when do we label somebody as having chronic constipation, what are different types of constipation, chronic constipation, and then I will come specifically to the primary classification of constipation and how do we treat that. So NHS basically says that somebody who's not passing 3 or more stools per week, the stool is quite large and dry, hard, lumpy, you're straining most of the time during defecation, and you have pain abdomen or feel bloated and sick. If you are having these symptoms or combination of these symptoms or any of these symptoms, then you can be labeled as having constipation. American College of Gastroenterology calls unsatisfactory defecation characterized by infrequent stools, difficult stool passage, or both. Difficult stool passage includes straining, a sense of difficult passing stool, incomplete evacuation, which is tenesmus, hard lumpy stool, prolonged time to pass stool, or need for manual maneuver to pass stool. So basically the purpose of putting this definition here is to tell you that it's a complex way of presentation. These patients don't normally present as we expect them to present with a simple thing as decreased frequency, but it can be a series of symptoms. So when do we label somebody in our clinic as having chronic constipation? So there is this criteria, set criteria, which we usually use in our clinical setting to label somebody, and chronic constipation must include 2 or more of the following symptoms or signs. During the last 1 week, at least 25% of the times, these symptoms should be present in a patient to label that patient as having chronic constipation. Straining, hard stools, tenesmus or incomplete evacuation, sensation of anorectal obstruction or blockage, and manual maneuvers to facilitate defecation. And the frequency should be less than 3 in a week. When these symptoms, any 2 of these symptoms or more are present, then we label somebody as having chronic constipation. Next, please. We usually use these tools in our clinical setting. This chart is a very easy way. You can hand it over to the patient. A lot of the times patients call constipation, the symptom, the complaint is very vague. They're not sure what constipation means, so they would use different terminologies for that. But in clinical setting, when we are planning to treat somebody, we need objective evidence. So these stool charts are there that we can hand over to the patients, and they can keep a record for a week or 2 and then come back to the clinic, and that gives us an objective assessment as to whether this is actually chronic constipation or not. And these Bristol stool charts are different, also used in the clinical setting. Next. The first thing when we see a patient with any bowel problem is to exclude red flag symptoms. This is the most important thing we have to do. We cannot move on to treat somebody with constipation as just hemorrhoids or just fissure and avoid red flag symptoms. So these are the red flag symptoms according to NHS guidelines. They are different in different setups, but the crux is the same, which is anybody with unexplained weight loss or abdominal pain with age more than 40, anybody with unexplained rectal bleeding with age more than 50, and iron deficiency anemia or change in bowel habits for more than 6 weeks in age more than 60. When you see these symptoms, you have to exclude malignancy. And for that, these patients are referred for, next please, either a colonoscopy, which is the gold standard. If they are too elderly or frail and they cannot tolerate colonoscopy or have a contraindication for colonoscopy, they go for CT colonography. And the third option is double contrast barium enema. This is quite obsolete these days. We don't use this anymore. Now, different classifications for constipations are used, but mainly the one we use in our setting is we label them as primary or secondary. Secondary constipation occurs as a result of underlying health issue. It could be neurological, it could be metabolic, it could be different, and we'll discuss that later. Whereas primary constipation is where the colon or the rectum itself loses its functional capacity. And this further includes colon transit, slow colon transit, IBS with predominant constipation, obstructive defecation syndrome, and functional or normal transit constipation. So first, when we see these patients in the clinic, the most important thing is we exclude secondary constipation, and that can be done very easily by a very good history and examination. That can exclude the drugs, any previous surgical intervention, any suggestion of psychological history, lifestyle, that the lifestyle activities are contributing, and then neurological and systemic diseases. All these can be excluded on a good proper history and examination. Next, blood tests. A lot of disorders which can lead to constipation, we can investigate them by routine biochemistry. And lastly, radiological investigations to exclude mechanical obstruction and neoplasms. So these are the ways of how we exclude secondary constipation in our patients. As you can see, this is the more common type of constipation, and it presents a lot to the medical setup. Next. Now, as surgeons, we don't deal with secondary constipation normally. That's done by the physicians because there is an underlying cause. So you need to treat the underlying cause in order to save the patient. But what we deal with is primary constipation. When these things have been excluded, there is no underlying pathology, then these patients come to us. And what we do is we put them in one of these labels, that either this patient has slow colon transit, that their colon is moving very slow, it takes a long time for stool to pass from one side to the other, and that is the factor, or the apparatus of rectum and anal canal that should work in a synchrony, that thing is not working properly, so that is defective. Or they have normal transit, but just because the stool is very hard or they have some functional problems, they are unable to pass stool. Next. So slow colon constipation, just further to tell, basically it's within the neurology of the bowel that you see that there is absent or decreased number of pacemaker cells in the bowel. As a result of that, the colon motility is reduced, and it takes longer for the stool to pass from one side to the other. And as a result of that, these patients do not feel the urge to go. This is the most important fact. You can tell easily with one question if your patient has either a slow colon transit or obstructive defecation. You ask them, do you feel the urge to go, or you don't feel the urge to go for days and days. If somebody is saying, I do not feel the urge to go to the toilet for 3-4 days and then I go to the toilet, that is most likely slow colon transit, because the rectum is where you feel the sensation. So the stool is not going to the rectum in time. So this is slow colon. And if the patient says, I do feel the urge, but I'm just unable to empty. I sit on the toilet for half an hour, 1 hour, and then even still I feel that it's not completely gone. So this is obstructive defecation. Next. So management starts with good history and clinical examination. We start with good history of frequency of bowel movement, consistency, is there straining involved or not, and most important, the urge to defecate. Examination, we can exclude a lot of defecating problems on examination, because defecating problems are mostly either anatomical or functional. So a good digital rectal examination can tell us whether this anal sphincter tone is adequate. There is a rectocele, which is a bulge of the rectum within the vagina. There is a pelvic floor descent with straining. There is dyssynergy or prolapse, etc. Next. So we have all these different types of investigations. After history, clinical examination, we have these tests that we perform in a colorectal clinic, and a lot of these are done as outpatient settings. So usually patients come to a rapid colorectal clinic, and anal manometry, balloon expulsion test, endoanal ultrasounds, these are done within the outpatient settings. Next. How do we decide which investigations should happen next? So what we do is that if the history and examination suggest obstructive defecation syndrome, as I said, the patient has the urge to go, sits on the toilet seat, is straining for hours, has to use manual maneuvers to empty the rectum, then we go for balloon expulsion test, followed by anal manometry and defecography. I will explain these further later on. Next. And if the history suggests that there is slow colon transit, then we go for colon transit study. And when we have the result of these, we can put them in this table, and that can tell us that what type of primary constipation my patient is suffering from. Next, a brief description about these tests. What are these tests? Because a lot of my colleagues might not be familiar with these. So balloon expulsion test is basically to check the capacity of the rectum. If the rectum has good capacity to retain stool or not, obviously that makes a difference. So what we do is we inflate a balloon, like a Foley's catheter balloon, within the rectum. At a certain point, the patient should start feeling the urge to go. If that capacity is reduced, then this patient has reduced rectal capacity, and that is a problem. So we need to deal with that. But if the balloon is inflating up to 100 ml of water, the patient is not feeling the urge, that's normal. But beyond that, again, that is a problem, because then you should feel the urge to go. So balloon expulsion test, and then we ask the patient to expel the balloon within the clinical setting. If the balloon patient is able to push out within 2 minutes, that's normal. If it goes beyond that, then it is abnormal. Next. Anal manometry. Anal manometry is a very common test we do in these patients. Like manometry anywhere, we basically measure pressure, muscular pressure within the anal canal and rectum. So the problem in defecating abnormalities or dyssynergy is that normally when a patient or anybody defecates, the rectum should push along with the abdominal muscles. This is the normal physiology. This is where the pressure is coming from. And the muscles of the back passage or the anal canal should relax. This is the normal synchrony of movements. When this synchrony of movements is disturbed, it leads to defecating problems. And this is very common. I mean, I thought this was only common in the West, but honestly, I'm seeing a lot of these here because people are having problems. And anything in our lifestyle can upset this cycle. You know, people are rushing to work in the morning, they delay their bowel habits, people are trying to hold, kids are trying to hold. So all these habits become chronic, and then these patients develop these defecating problems for life. And because it's a social stigma, nobody discusses this. And they keep on going with, and then you keep seeing them with fissures and hemorrhoids, and we keep treating that rather than treating the actual problem. So anal manometry basically tells us that is the rectum pushing enough? Is the anal sphincter or muscle relaxing enough? If this is not happening in a synchronous way, then we have a problem. Next. And defecography is basically a test which gives us anatomical description of what is going on. So we put a barium contrast enema through the back passage, and we ask the patient to excrete. And when the patient excretes, two things happen. Number one, either it's normal, as you can see that the contrast will come down without any bulges, without any prolapse, or without any intussusception. Or we can see that you can see a bulge at the front, which is called a rectocele. So basically, very common in our female post-delivery. They are straining and straining, the muscles get weak, and the rectum starts to bulge towards the vagina. Or any previous episiotomies and perianal procedures, these can lead to these rectoceles, and these rectoceles then, obviously, if you have a pouch at the front, the stool, that muscle is gone. So it's not going to contribute in pushing the defecation downwards. So it's an anatomical problem which we need to fix. Or most common here, intussusception. I have already seen 4 or 5 of these patients, and even more are coming, with this rectal intussusception. So what happens is every time a patient is sitting on the toilet, they're straining, the rectum invaginates within itself. Now we can't see it on the outside, so it's not a problem, but actually on the inside it is happening. So defecating proctogram is an ideal investigation to give us this information. And this is an anatomical problem, so needs to be fixed as well. And lastly, colon transit study. So basically, this is very easy way to find out. It's very common sense kind of a test that how you can tell somebody has a slow colon. So these radio opaque tracers are used in a capsule, The patient eats the capsule on a Sunday, delivered by post. This is what the practice in NHS, but different setups have different ways. So the patient gets a capsule in the post, eats it on a Sunday, comes to the hospital on a Monday, gets an X-ray day 1, gets an X-ray day 3, and gets an X-ray day 5. By day 5, all these tracers, which you can see all the X-ray, these tiny dots, they should disappear. If they are out of his system, then that means this patient has the capacity to empty the colon within the given time frame. But if you have done an X-ray on day 5 and still the tracer is all over the place, then that means this is slow colon transit. Next. So what are the contributing factors, or what can we do to fix this, you know? So the treatment starts lifestyle modifications. Most important factor. 80% of the treatment can be done with lifestyle modification and simple, you know, medical therapy. Diet, what are we eating? Junk food, high carbohydrate rich diet, taking meals very quickly, eating meals, inappropriate meal eating habits, stress, too much coffee or caffeine, lack of sleep, lack of physical activity. I mean, it's just a long list of things which we do that contribute to our abnormal bowel habits. Next. So the solution starts with changing these lifestyle habits, you know. We should watch our diet, what we are eating. Eating more fiber is helpful. Normal human male should take approximately 30 to 35 grams of fiber a day. And how do we calculate? Each portion, we can Google it these days. It's very easy. You can Google how much fiber you need in a day. And that portion should be calculated for each day, and we should have that in our diet every day. This is very important. This is not just for constipation, for any bowel pathology. If you want to keep your colon happy, you need to have good fiber every day. So 30 to 35 milligrams of fiber for male and 20 to 25 grams of fiber in a female every day should be there in the diet. Fiber is green vegetables, dalein, chokar ki roti, you know, brown bread. All this is basically fiber. We have this in our diet. We just need to make it regular. Second, increase fluid intake. So when we eat too much fiber, fiber gives bulk to the stool. That means now this stool can pass through the colon as one unit. But that fiber needs plenty of water to make it moist, to make it soft. So good fluid intake. A normal adult should take 1.5 से 2 लीटर पानी रोजाना अपने मरीजों को कहें पिएं. Generally, हमारे इधर with dehydration, it's even more important. And lastly, exercise. Everybody should do a walk. I think this is not just for constipation; it's for everything. You know, for your heart, for your lungs, for your everything. So basic lifestyle modifications. You eat good fiber, you exercise, and you drink good water. That's it. This is the basic stuff you can do to improve your bowel habits. Next. You've done all your lifestyle modification. You've done an assessment of your patient that, you know, the patient is not doing anything unusual. The lifestyle is pretty much close to baseline. So what next? Then your patient is probably having a mechanical problem. It's a colon transit problem. It's a defecation problem. So your patient then needs medical treatment. Now, medical treatment, as you can see, it's a big list of things, you know. I'll summarize this later on and kind of make it a bit more simple. But you have bulking agents, you have osmotic laxatives, stimulant laxatives, and the names suggest what they do basically. Bulking agents give bulk to the stool, it's same as fiber. Osmotic laxatives increase the, you know, the water input. Stimulant laxatives stimulate the gut. Lubricants lubricate the stool, stool softeners, and then combination of the above. Next. The first line when we see a patient in our clinical setting is that we start with basic natural stuff. So fiber is natural. So we start the patient on a fiber diet. If they're not able to take enough fiber, even then you can prescribe them bulking agents. So bran, isfagol, and methyl cellulose. All these are different ways you can increase the amount of fiber in a patient, and this will help them along with good hydration in having a normal bowel movement. So this is the first line of therapy, over-the-counter normal fiber input. Next, first line therapy, we can also use these products as rogne mongphali, you can use stool softeners, milk of magnesia. These are, again, they don't have side effects, they're simple to use, they're over-the-counter, and patient usually considers this as a home remedy, you know, so it's not considered as a medication, so compliance is very good with these things. Next. First line fails. So now we move on to the second part. The second line includes now we have to give them osmotic laxatives. So these osmotic laxatives, the most common we use, you can see these names, Dufelac, Lilac, Movcol, all these are used as the second line therapies. So we give these to the patient regularly to make their bowels regular. Next. Then stimulant laxatives. Stimulant laxatives are very tricky. We use them without any proper plan, but stimulant laxatives are there to be used for short period of time as rescue therapy or as a second line in combination, but they should not be used for a long period of time. And it's common sense. It's going to stimulate the gut. So chronic use with these can lead to chronic pain and problems, you know, indigestion, bloating. So you cannot use these for long term. So use them as rescue therapy that you're giving first line. The first line is not working. You use this for a week, empty the colon, and then go back to the first line. So this is how you regulate. So you give stimulant laxatives. There are different options: Senna, naturally, castor oil, sodium picosulfate, Skylex. We use in kids a lot this Skylex drops, and bisacodyl and glycerine. So no long-term use, short-term use, week spell of 1 or 2 weeks, and then go back to first line medications. Next. Now, patients can be refractory to these, and the patients that I see in my clinical setting or the patients we normally come across in surgical specialty, with primary constipations, they will be refractory to all these drugs eventually. So in Pakistan, unfortunately, I think the only option, probably, Ashfaq, if you can correct me, is Reslor, isn't it? It's available. I Googled it, it was probably being marketed, but I don't know if it's available in our setting. These are all different types of drugs which are third line therapy. They are being used in the West. They are used only when needed because they have potential side effects, but they are good when you are left with no other option and you want to avoid surgery. So prucalopride is the most commonly used drug outside, which is Reslor. So 2 milligram Reslor is given at night and it just runs through you. It just runs through your colon, you know, it will empty any colon. But obviously it cannot be used, you know, too much. Lubiprostone is being used especially in opioid-induced constipation. This is a drug of choice. And then linaclotide is used in especially IBS with predominant constipation and refractory chronic constipation. Next. So when medical management fails, what happens? We are left with no choice. We have to think about the patient and we have to give him some or her some relief. So we go for interventions. Next. So surgical options in slow colon transit. What are our options? So slow colon transit, unfortunately, as I said, it's a nervous problem. It's not always limited to the colon. And in my clinical experience, I have done subtotal colectomies for this once or twice and ended up regretting. The reason was that it's a global problem. They develop gastric paresis, they develop small bowel problems. In the end, the patients continue having problems. So it's not an easy fix. Surgery should be the last choice, or it shouldn't be if you can avoid it if possible, you know. But again, in literature, you can find neuromodulation. What is neuromodulation? So you stimulate the nerves, and the most important, because large bowel is being supplied by hypogastric plexus, so you put a small probe in sacral S3 foramina, stimulate the sacral nerve, stimulate the hypogastric plexus, and that leads to some motility improvement. This is the most simple way of doing this. If this fails, you have antegrade, basically colonic enema, where I'll show you the picture later on to give you a concept of what it is. Last resort, nothing is working, patients is not, and I've seen this, 14 days, even 20 days, not going to the toilet. And then they're blocked up, they're having manual evacuation. So in these patients, they do end up with stomas, small bowel ileostomies, because they need some quality of life. And last is subtotal colectomy with ileorectal anastomosis or stoma. So these are the kind of rescue after lots of counseling, telling your patient you may still end up with the same problem because you have a global problem. But for now, we can consider stoma. Next. Next. So this is sacral nerve stimulator. You can see from the, I don't have a pointer with me, but basically in S3 foramina, it's a very simple procedure done under GA. The patient is prone. We put a small probe within the S3 canal. As soon as it touches the sacral nerve, you can see the flexion of the toe or a wink in the anal canal. So that gives you that the probe is in the right position. And based on that, we place a small battery in the back here. So this basically has a life of 10 years. The patient can use this, and with this, the nerves are constantly stimulated and their constipation is improved. The results are only 50 to 60% still. It's not 100%. Next. Antegrades. So through the appendix, we put a catheter into the colon, and that's permanently there. Now these patients usually cannulate. They put the catheter in every morning. They wash the colon. They sit on the toilet seat with the drip at the start. The drip is started. The colon is washed all the way down to the rectum, and then they get on with their day, because now they know that it's empty, so they have a full day. They can carry on with their activities. But as I said, not a very easy option to convince your patient. Next. And lastly, having ileostomy and subtotal colectomies. Next. Obstructive defecation. As I said, this is a problem with the synchrony of defecation. The problem is in the apparatus of defecation. So functional problem include anismus or dyssynergy, and this is the most common type. Because of our habits, because of our lifestyle, we ignore our bowel habits. As a result of that, we develop these abnormal bowel habits. So once that happens, then it becomes a constant problem, and especially in kids. We see this, that they try and hold because they're playing or something, because they will, to try to avoid anything to go to the toilet, and these things develop. So this is anismus. Next. Then there are mechanical. You have actually something wrong with the gut mechanically, anatomically, like a rectocele, enterocele, or intussusception, as I've shown you before. So how do we fix this surgically? First, we grade these patients based on this. We calculate the severity, and if there is a good severity score, only then again we go for interventions, because in this case as well, interventions are good. They have good results, but there are still no 100% guarantees. Next. So this is the normal defecation reflex. In a normal defecation reflex, the puborectalis should relax to straighten up the colon, and in this case, the squatting position is very important. These modern toilets do not give us enough squatting position. So that's why a lot of people sit on the toilet seat straining and straining, but actually putting a small stool in the front can help, because that gives you a proper squat position, relaxes the puborectalis muscle, and then it becomes a straight passage for the stool to come down. Next, the rectum and abdominal muscles should push down. And lastly, the anal sphincters should relax. So three things should happen in a synchronous way for a normal bowel movement to happen. But this goes wrong a lot. Next. So how do we treat anismus? Laxatives, enemas. Again, everything starts with medical therapy. We cannot go for surgery straight away. Next. This is the mainstay of treatment, biofeedback. This is a treatment modality where visual auditory stimulus is fed into a computer program, and patient has a probe within the rectum. Now, based on the commands given to the patient's activity is monitored on the computer, and patient is used to is basically trained again. This is having your toilet training all over again, because what this program, this computer software tells you is that you are contracting at the wrong time, you're squeezing at the wrong place. So whatever is happening is fed to you back, and then you can change that. So you need sessions. It usually takes 3 months of sessions, 15 days apart. It's just a computer software. I don't know if we can get it here at some point or not, but it's a simple thing. And this is the main treatment. You train them again based on visual and auditory feedback, and as a result, this problem can be sorted. Next. If biofeedback fails, this is tried. It works in 50% of the cases that we put Botox in puborectalis muscle, which again relaxes and paralyzes. So at least one factor of puborectalis sling is gone. Next. Then surgery for rectocele. Rectocele, as I said, is a mechanical problem. There is a bulge within the rectum this is very common in our female patients, especially after childbearing age. They have a lot of this problem, and the treatment is you fix that bulge, you get rid of it. So there are transvaginal repair, usually done by gynecology colleagues. This come in their domain as well. There is transperineal repair, and then what we do and what I perform is STAR procedure, which is with a stapler we just resect this redundant extra tissue. Next. So this is just a brief description. So what we do here is that basically patients have these extra mucosa which is hanging. So we take suture through this redundant mucosa, and we pull all of this extra mucosa within the stapler. The stapler closes, we fire, and in the next, the mucosa is pulled in, and then in the end you have a straightened mucosa with stapler cross. So basically the defect or bulge is straightened up by taking that within the stapler. So this is STAR procedure, which is stapled transanal rectal resection. Next, for internal intussusception, what are our options? Again, STAR procedure, we can take the extra redundant skin through the SCAR procedure, and the most common in West, the most practiced, especially in younger population, is mesh rectopexy. The concept of rectopexy is that the rectum lies on the sacrum in a curved way. That leads to angulation, and these patients feel problems. So we straighten up the rectum surgically, like it's done over there. We have straightened up the rectum, lift it off the sacrum, and we fix it to the sacrum. And that way, the straightening of the rectum and the colon, that leads to basically easy passage of stool. We can sometimes put a mesh to fix this in that place as well. Next. So in summary, medical management, first line, second line, rescue therapy, and then third line. First line, usually over-the-counter drugs. Don't go for osmotic laxatives or stimulant laxatives straight away. Keep them for your second and third line. If they all fail, we can use scretagogues, which is lubiprostone lactodide if available, or prokinetic therapy if available. Next. And this is summary of intervention in obstructive defecation syndrome. As I mentioned, that basically you try with medical therapy. If it fails, then you treat individual problem. For rectocele, it's intervention, surgically fixing it with STAR procedure or perianal approach or vaginal approach. With the prolapse, it's STAR procedure or rectopexy. And for simple slow colon transit, as I mentioned, surgery should be avoided, but if you needed, neuromodulation is the best therapy. Questions?
So maybe those excesses will actually complicate the problem more.
So yes, thank you. So the question by Dr. Muntasir is that at what point during the medical treatment of a patient should a physician start thinking about investigations, if I'm correct, yeah? So as I mentioned later on, that even with mechanical problems like rectoceles and intussusception, the first line of treatment should be medical. So if a patient is with a physician having laxatives, then that should be the way it is. You know, we're not missing something too aggressive. It's only that when that fails, we think about other options. That's first point. Second is that, as I said, red flag symptoms. So most of these patients, they normally have had a colonoscopy beforehand, which can give us some clue. Colonoscopies, like Ashfaq performs them, I do get reports about solitary rectal ulcers or other things which indicate mucosal prolapse. So that is one way that most of the patients usually are coming to us after having colonoscopies. Colonoscopy would be the first test in any case. I think I didn't mention that or emphasize on that, but colonoscopy, irrespective of anything, should happen in any person who has chronic defecating problems, because that at least excludes any sinister pathology. Then comes the medical therapy, and when the patient is failing for 3 months, 3 to 6 months, different variable setups. Obviously in NHS there is a long waiting list, they leave the patients for 6 months. In your setting, if you have tried this for 3 months, first line, second line, and after 3 months the patient is not responding, then should be investigated with all these tests. The problem with these tests is they're not available. Anal manometry, Lahore. Deficogram, I have discussed with Dr. Urfa, and thankfully our technician MRI was doing this in Saudi, and he knows how to do this test, and inshallah in the next week or two we're going to start this test over here, because he said he just wants to do some tweaking of the machine, and then we're going to start deficogram, because I have 4 or 5 patients who are waiting for this. It's not offered anywhere. It's a simple test to read. You just need to see invagination or rectocele. It's not rocket science. So we're going to try and get this done over here. So this is important. So investigations are done because they're costly, they are time consuming, and they're not readily available. So they should be given a time where you try all these medical therapies, 3 months to 6 months, failing, move on to the next thing. But before this, colonoscopy should have happened already. Yes, because we don't want to miss any sinister pathology. I hope that answers the question.
Moreover, I think constipation is not considered with respect, even by the physicians.
With the physicians, yes.
And general public, they say
Exactly.
plus try this and
Yeah.
then salad from Hakeem and
Yes. Yes.
and
Yeah.
usually even in pediatrics,
Yes.
patients are suffering from 6 months to a year before they start coming to a specialist.
Yes. Yeah. Yeah.
So,
Especially Hirschsprung and all that as well. Yeah. 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 Yeah.
Hirschsprung and even I would say in pediatrics, out of 100, only 2% cases are Hirschsprung.
The rest
98
functional.
are
Functional. Mhm.
So I was just curious to know what is the prevalence of this neurological disorder and constipation?
So basically, the primary constipation prevalence is around, you can say, like, in all the constipations, primary would account for 20% of all the constipation patients, but these are all foreign figures. I don't think I'll ever find a Pakistani figure. I tried Googling, but I didn't find it, and it's not going to be possible because it will not be true representative picture, because people, as I said, don't think this is a problem. But
I can give you our statistics.
all right.
At the university before our pediatric gastroenterologist joined, about 25% patients attending our clinic were not.
Oh, really, that's a huge number.
When
Yeah.
I transfer all of them except those with an hospital problem.
To gastroenterologist. Yeah.
It's really a problem. It's as common as diarrhea.
Exactly. Yes.
Because diarrhea is a very celebrated symptom.
Yes.
Worldwide,
Yes.
and
Everybody takes it seriously. Yes.
at the WHO thing, gastro all this.
Yeah.
Constipation, I don't think has received much attention in pediatrics. Adults, even in adults,
What medication would you stop when you first see a chronic constipator? What medication you would absolutely say that we should get rid of?
Antidepressants are the most common medications which would lead to this, antidepressants. There are some anticholinergic drugs, antidepressants. These are the more common ones. Iron, a lot of women taking iron tablets, that can contribute. Stopping is a different thing because I would consider the pros and cons, that the indication versus the benefit. But these are the more common. There is a huge list. There is a long list. I don't even remember most of them. I would probably open up a chart in front of me before taking history. But yes, the most common is antidepressants and anxiolytics, opioids. These are the more common abuse drugs, which basically, because we prescribe here we prescribe all these drugs very easily. Somebody not settling amitriptyline, or something. so it's a common thing. So that can lead to this problem.
these laxatives are very misused drugs. One of
Exactly.
the very
Very misused drugs. Yes. And as I said, stimulant laxatives. बच्चों को Skylex देते जा रहे हैं.
We're talking about fourth generation drugs, which clean and
Yes.
those receptor drugs. I think it's just it's just like giving a razor in the hand of monkey.
I think it all comes down to awareness. In the West, they have realized diet is important, lifestyle is important. They will try to avoid medical therapy as much as possible. They would come back to the clinic and say, no, I've tried, I'm working on this, I'm optimistic. They will keep trying it, or diet, fiber, drinking water, bottle in the hand all the time, moving around, So it's awareness makes a huge difference, especially in this area. Yeah.
Same with I have started during my career general surgery as well as constipation has many problems. Unless you understand the pathophysiology and everything, you can't
Treat it.
scientifically,
Exactly.
and it's just then it's hidden in the dark.
Exactly.
Try one laxative after another, one after another. कभी आप कभी
ज़रा chronic constipation secondary की slide लगाना ज़रा. If you just look at this, the possible causes of secondary constipation, nobody has time to exclude all these in a clinical setting. This is the problem, you know. That is why we need to develop, I think, these performers or questionnaires where patient takes them home, fills them up and brings them back, you know, which can be evaluated. Because if you look at the causes, I mean, it's like 150 causes. And in a clinical setting, a surgeon cannot say, you know, that you have any neurological problems, and then within that neurology, what's the further diagnosis. So it can be very difficult. So I think questionnaires.
What you can do, we did it in our clinic. We made this questionnaire. And our nurse will ask, constipation was such a common.
Yeah.
We will ask what is the problem. Why
Yes.
you have some constipation.
Yeah.
Okay. Fill up while you're waiting.
While you're waiting for the, exactly. Yes.
So I think
Yes.
that might be good in our setup.
नहीं नहीं बिल्कुल सर बिल्कुल. All good? All happy? Sir, thank you.